All right, I know. So far, it's been growth hormone this and prolactin that. I get it. We've been focusing too much on the anterior pituitary. Well, as promised, it's time to explore the dark side of the hypophysis. The posterior pituitary is responsible for secreting oxytocin and antidiuretic hormone, or ADH. ADH is going to be the main feature of this sketch because, as the name implies, this hormone makes you not diurese. Conserve water, that is. And this can have some pretty dire consequences when all goes awry. So, because conservation of free water by the kidney is the name of the game, we're headed to one of the most famous fountains in the world. The Trevi Fountain in Rome, Italy. Initially commissioned way back in 1629, construction didn't get underway until 1732, based on a design by Italian architect Nicola Solvi. At the time of Solvi's death in 1751, his work was only half finished, and it took another 10 years of construction before the massive ornate structure that we know and love today was complete. Much later, in 1998, the fountain was refurbished for the first time, and recirculating pumps were installed. Sounds kind of like conserving water, doesn't it? That's exactly the function of ADH. Whoa, no drinking. That water is non-potable, amico mio. Luckily, we've brought our water with us. In this convenient posterior backpack. It's our recurring symbol for ADH from the posterior pituitary. The other hormone secreted by the posterior pituitary is oxytocin, embodied by our recurring oxytocin ox. When a pregnant woman is in labor, oxytocin is released and activates contraction of the uterine smooth muscle. Oxytocin is also released in response to a baby suckling on the breast and stimulates the smooth muscle surrounding the lactiferous ducts and mammary glands, at which point it's milky times. All right, you see the fancy new electronics they've installed around the fountain? Let it remind you that while the anterior pituitary acts like its own hormone-secreting gland, the posterior pituitary is more like a direct extension of the brain, hence the other name, the neurohypophysis. The posterior pituitary is even derived embryologically from neuroectoderm. What this means is the hormones secreted by the posterior pituitary don't actually start there. Oxytocin and ADH are made in the paraventricular and supraocular nuclei, way up in the hypothalamus. So, on the wall, we've placed a nucleus-like transformer next to that vent and above that ocular security camera. You might even say paraventricular and supraocular. Eh? From there, follow the wire. Oxytocin and ADH are then transported down axons into the posterior pituitary and stored there in nerve terminals, waiting for release. As a result, even if the posterior pituitary is damaged, these hormones can still be released from the hypothalamus right into the systemic circulation. Joke's on you, pituitary tumor. Okay, time to get hormonal. We're going to spend the rest of this sketch focusing on antidiuretic hormone, which is also known as ADH or vasopressin, or even AVP if you're a volleyball fan. This hormone plays an important role in maintaining plasma osmolality. It puts the osm in con osmens. Technically, plasma osmolality is the amount of plasma solutes, measured in osms, divided by the amount of solvent, measured in kilograms. Put another way, it's all the stuff dissolved in the plasma, divided by the plasma it's floating in. Think of it as a concentration. I want to emphasize as well that we chose ketchup so that you connect the color red to serum concentrations. Later we'll bring in mustard, but that's for urine measurements only. Osmolality is derived from the serum sodium, serum glucose, and BUN levels. These are the three big solutes. We can simplify it even more, in fact. It turns out that out of these three, sodium is actually the most prominent solute. See all those salty sodium peanuts back there? So, when sodium levels are rising, imagine osmolality rising along with it. Since normal serum osmolality is between 275 and 295 milliosmoles per kilogram, we put a 3Cs logo on the condiment stand to remind you of elevated levels in the range of 300s and above. In Italy, 3Cs equals 300, in case you didn't know. All right, back to ADH. The principal regulator of ADH secretion is plasma hyperosmolality. Your blood's too concentrated, which usually means too much sodium, remember. A 1 to 2% increase in plasma osmolality stimulates the osmoreceptors in the hypothalamus, which tells the posterior pituitary to secrete ADH. Another stimulant of ADH secretion is hypovolemia, or decreased blood volume. Typically, you need about 10 to 15% decrease in blood volume for this to occur, which is kind of a lot. Before that happens, the renin-angiotensin-aldosterone system is the main controller of blood volume homeostasis. Hypovolemia can occur in the setting of dehydration or blood loss. Remember, too, those patients with cirrhosis and heart failure. They may have lots of fluid in their lungs, legs, and abdomen. So technically hypervolemic, but probably not much volume in their arterial system. With decreased effective arterial volume, the hypothalamus tells the posterior pituitary to secrete ADH. All right, where does ADH go from here? Well, there are two main peripheral vasopressin receptors, creatively named V1 and V2. V1 receptors are located on vascular smooth muscle and activate GQ proteins. Notice the Q we've highlighted next to that first V. GQ works to increase intracellular calcium, thus promoting vasoconstriction, as depicted by those tight red straps. This increases blood pressure, really putting the pressin in vasopressin. V2, on the other hand, is in the kidney. Specifically, these receptors are located on the principal cells in the renal collecting tubules. This is where they activate GS proteins. So this time, notice the S we've highlighted next to the second V. GS helps to upregulate the expression of aquaporin channels, thereby increasing the reabsorption of free water at the collecting duct. Free water means without electrolytes. Water only. And it's free, so why not? So let's put it all together. If your osmolality increases too much, ADH kicks in to preserve water and dilute the blood. If volume drops too much, ADH kicks in to increase blood pressure and increase water volume retention. We can even administer exogenous vasopressin in cases of shock to help boost blood pressure. Now that you understand the normal physiology, let's see what happens when your ADH ain't working. First up, diabetes insipidus, or DI for short. In DI, there's either a lack of ADH, which is called central DI, or a lack of renal response to ADH, which is dubbed nephrogenic DI. Central DI is embodied by Bradino over here. The word central should remind you of the central nervous system, which is where the hypothalamus and the source of ADH production is located. In central DI, the hypothalamus is not making enough or any ADH, while kidneys are functioning normally. See that leaky pack on his back? Equate central with low ADH. In nephrogenic DI, the problem is in the kidneys. Nephrogenic DI is caused by resistance to ADH. See how this other tourist here is resisting that water peddler? Jesu Christo, can this guy take a hint? She doesn't want free water, okay? You're being weird. Anywho, when you think of resistance to ADH, imagine that the hypothalamus is making ADH just fine. See how her ADH pack is completely full and functional? The posterior pituitary secretes it without a problem. ADH heads over to the collecting duct and, there's no receptor to bind. Or let's say there are receptors there. Okay, fine. ADH then binds to V2 like it's supposed to, but then nothing happens. The aquaporins are all messed up. So overall, either you have low ADH in the setting of central DI, or your kidney resists ADH in peripheral DI. In both cases, aquaporin channels don't get activated and you have a hard time conserving free water. You pee it out instead, naturally. This leads us to our recurring symbol for diabetes insipidus, a perpetual fountain of dilute insipidus urine. Now, a healthy kidney is capable of producing urine with a concentration ranging from 50 milliosmoles per kilogram up to a super concentrated 1200 milliosmoles per kilogram. In the setting of DI, when all that free water is getting excreted, patients usually present with inappropriately dilute urine, usually somewhere under 300 milliosmoles per kilogram. Again, we've got the 3 C's to remind you of 300. So Roman. And it's not just dilute urine. It's usually too much urine. That's polyuria, defined as daily urine output over 3 liters in adults or 2 liters in children. All this loss of solute-free water means that a higher concentration of sodium is left behind in the serum. In doctor land, that means hypernatremia, which is defined as a serum sodium greater than 145. In sketchy land, that means elevated trays of salty sodium peanuts. The ins and outs of hypernatremia are covered in more detail in the Fluids and Electrolytes unit, so check out that sketch if you haven't already. Also, remember that increased sodium goes hand in hand with increased plasma osmolality. Sodium is our dominant solute in the serum. Symptoms of hypernatremia can be pretty vague and include lethargy and weakness. If it gets worse, though, due to cellular fluid shifts in the brain. Hypernatremia can also lead to altered mental status, hyperreflexia, seizures, and coma. Luckily, your hypothalamus has a trick up its sleeve. As you know, increased plasma osmolality activates osmoreceptors in the hypothalamus, which, in turn, tells the posterior pituitary to secrete ADH. Well, that's not going to work in a patient with diabetes insipidus. The hypothalamus isn't done yet, though. It also stimulates thirst. As you can imagine, increasing water intake can help dilute the sodium and decrease serum osmolality. In fact, in most cases of diabetes insipidus, increased water intake from increased thirst is enough to keep sodium levels only mildly elevated. Patients at risk for profound hypernatremia are infants, the elderly, and people with conditions prohibiting them from increasing fluid intake. They just don't have access to water. Okay, now that we've covered the general pathophysiology of diabetes insipidus, let's briefly illustrate a few reasons why it's even happening in the first place. In central DI, remember, the problem is at the hypothalamus, the central source of ADH production. There are a variety of causes of central DI, and about 30 to 50% of cases are idiopathic. Idiota. Studies have found that many of these idiopathic causes probably involve an autoimmune component, causing lymphocytic infiltration and destruction of the pituitary stalk and body. Tumors in the brain can also cause central DI if they affect the hypothalamus. Notice that I didn't say pituitary adenoma. Remember that ADH may be stored and secreted by the pituitary, but it's made in the hypothalamus. Turns out that, in most cases, knocking out the pituitary with a tumor won't have much effect on ADH release. The hypothalamus is able to release the ADH into the circulation by itself. Surgery in the region of the pituitary and hypothalamus can lead to both transient and permanent DI. Other causes include trauma and infiltration of the pituitary in Langerhans cell histiocytosis, Wegener's granulomatosis, or sarcoidosis. Main point here? Brain stuff. How about nephrogenic DI, which is caused not by deficient ADH, but by resistance to ADH at the level of the kidney? As we discussed earlier, there are two scenarios here. Either ADH gets to the renal collecting duct but has no receptor to bind, or there are plenty of receptors, ADH binds, and it's the aquaporins that aren't working properly. The most common causes of nephrogenic DI involve the latter scenario. Lithium therapy is the most common etiology in adults. Up to 20% of patients chronically treated with lithium develop DI. Lithium enters the principal cells in the collecting duct and prevents proper aquaporin formation. In some cases, this effect is irreversible, even if the drug is discontinued. Hypercalcemia can also cause nephrogenic DI, though the mechanism by which it interferes with water resorption has not been totally worked out. Hypercalcemia may decrease the amount of aquaporin channels in the collecting tubules. Hypercalcemia itself can also cause diuresis due to an osmotic effect. And thirdly, in patients with chronic calcium levels greater than 11, hypercalcemia may inhibit salt reabsorption in the thick ascending loop of Henle, which in turn screws up the concentration gradient in your kidney. In simple terms, ADH binds to its receptor, aquaporin channels form in the collecting duct, but water has no concentration gradient to move down, so you still pee out all that free water. Our last etiology is genetic. Hereditary nephrogenic DI is caused by mutations in the genes encoding either V2 receptors or aquaporin channels. As a result, ADH either has no receptor to bind, or after it binds at the collecting duct, the aquaporins never make it to the cell membrane. Okay, let's take a look here. A patient comes to your office with polyuria, let's say a few liters per day, dilute urine, less than 300 milliosmoles per kilogram maybe, and polydipsia. They're thirsty all the time. Typical diabetes insipidus, right? Well, there are three major etiologies you need to keep on your differential: primary polydipsia, nephrogenic DI, and central DI.